extended.
Well, I think that's right. I mean, it would make a lot of difference to me to be able to see my kids through another, N years of their lives. So I think years added there would be meaningful, and I think this would certainly add a lot of years. Now, how many, I'm not sure, but certainly some.
Thanks, Mike. Paul, I want to ask you a question. We've done some work on the impact of children on the family and interventions in developing countries, where we've seen that when we educate young, in fact, we started with preschool children in Colombia, and it's extending now in Spain with Valentin Fuster's work to early school-age children, that we actually impact the family when the children get educated. So I'm just wondering, how do you incorporate, or do you incorporate the family into this intervention? Because that seems, if you look at most families, it's the wife or the spouse or the children that are motivating some of these guys in their 60s who are now facing an exercise program.
Absolutely. I think so involving children, families, other kinds of units. We do this better when we do it as make it more of a societal norm, right? So if we extend out the family kind of structure, the more that we can get on board embracing healthy living, the better we're going to be. So for our patients in our programs, for instance, they struggle when they find that there isn't that support at home. On the other hand, they'll thrive when there is. For us, there's behavioral kind of theories, constructs for this. For us as healthcare providers, if we extend this even further, why it's so important is that if this becomes the norm, that we're healthy, that it makes the transference so much easier. So if we lead a healthy lifestyle, and that's the expectation in our practices, that transference can happen. And if we work on children, parents, spouses, that transference will happen as well.
Yeah, now to extend that further, there's been some proposals in the WHO and from the non-communicable diseases committees that met in New York, the issue that we can intervene on communities through an Alcoholics Anonymous type of intervention, where it's not, our people don't usually respond to someone, some trainer or some authority figure telling them what to do, but rather their neighbor buddy system. Have you had any experience with that, or have you observed that in your own practice?
I think that it kind of speaks to the power of peer support, and maybe leveraging peer support in all of our practices. One program we're developing is developing peer mentors. People who graduate the program, they may be the strongest advocate and the one that can actually model the behavior and issues much more strongly than the healthcare professional as the expert. The explosion of chronic disease management programs in all of our practices, what we see there is a peer leader is the one that should lead this. How best do you cope with your illness? How do you overcome barriers? How do you do this successfully? So that the power of the individual that's already been through that should be harnessed.
Yeah, that's great. Vicki, we have a question from the audience for you. Are not all the responses of stress, are the coping styles, are they not is there a mixture of the three? Are they not always so, they're not always so distinct? Is that true?
They're not always so distinct. We often find that probably about 10% of our participants will have sort of a combination of them. So you'll have people that tend to be habitual towards one or the other. What we do know, though, is that regardless of what your profile is, if you tend to be high on avoidance, regardless of what you are elsewhere, we do find that pattern of low subjective responses with the high physiological responses. But yeah, you can have a mixture. It's just that the task-oriented and emotion-oriented, depending on the type of stressor, tend to be the healthier, but avoidant anytime you're high, regardless of what else you are, it tends to be a risk one.
So how would family physicians pick this up? They're busy, there are multiple visits in an hour. I don't even want to think about it because it's more than what we do in cardiology. But obviously you're busy, and the idea of how can we detect this? Is there a simple questionnaire that can be administered?
Yeah, there are simple questionnaires. One of the problems is that the people who are avoidant copers might also avoid going to the doctor, unfortunately. So the first thing is you have to get them. There are
you seem to love to come to us, right, Mike?
Yeah.
There are very simple validated skills to measure chronic stress. So there's one, the Cohen Perceived Stress Scale. It's a very simple 20 question that looks at it, and there's a couple of questionnaires for coping styles, the ways of coping styles and the coping inventory for stressful situations. It takes less than 5 minutes, and people can fill it out, and it'll give you an idea of what a coping profile is.
That sounds great. Now, the other question is there, in terms of stress reduction, this is another question from the audience, is there evidence for the mindfulness-based stress reduction program? Do you know about this?
There is some evidence for it. The mindfulness stress reduction is one of the ones that there is some evidence to suggest that it is effective. There's some mixed results. The other ones that has typically quite a lot of evidence in favor for it is cognitive behavioral. So ones that mix sort of mindfulness or relaxation training, and some that will mix the reframing or the cognitive restructuring of the way people deal with it. So a mixture of relaxation and reframing or changing the coping styles tends to be the ones that are very effective over short periods of time, and that can be very easy to administer. And most of the research is in terms of subjective stress, but there's starting to be some evidence in terms of physiological stress as well.
And do you observe, as we have, and Paul might comment on this as well, post-myocardial infarction, for example, people will modify risk factors, stop smoking for the first 6 months, but by 1 year they drop back to where they were at baseline. Do we see similar things with stress reduction? Or because it could be that it's shaken their system so much that they may actually
Yeah, I mean,
develop a new...
That's the nature of human nature, right, is how do you, I mean, thinking, this is putting my psychologist hat, is how do you create something in terms of a habit, and not just the fact that you're scared and you're paying a lot more attention to things, and how do you prevent that sort of slide back to bad habits, and that's where we do know that social supports and having an environment around you is going to be much more likely for you to develop a habit. And the same idea from the sports perspective, it's slow changes that happen over the while, but there hasn't been that much research looking at the long-term interventions of stress management and that slide back to resume. And I think we do need to have more research.
Yeah, I just think everybody needs to be aware of that, because we always get caught up in the hubris that, at 6 months everything looks great, and they may not even come back routinely after that, but that 1 year mark seems to be where you can decide whether they've slipped back to baseline, and an important measure. Mike, another point from the audience, the current obesity and diabetes epidemic that it seems to be occurring now, unfortunately, more commonly in the late adolescence and early adulthood. When will we see the impact on cardiovascular disease? So we're on this wave of pre-diabetes and diabetes. Are we going to see in the next, are your children going to be paying for this, for example, in terms of 30 years from now, 40 years from now, are we going to see a situation that's untenable?
Well, I'm not sure exactly how to answer that. Clearly people who have risk factors that aren't controlled are going to go on as a population and have the disease. So one would contemplate that the prevalence would be relatively high of the disease N years from now in people who have a lot of risk factors.
Yeah, so is it that we're detecting this earlier?
Oh, I suspect our lifestyle is pretty poor. There's a lot of there's an awful lot of eating of food that certainly isn't the hunter-gatherer diet. And I do think, though, that, I think it's fine to talk about behavioral modification, but one of the concerns that I have, and this is not necessarily a politically correct thing to say, but, it's probably true that if we adopted dramatically different lifestyles, there would be a dramatic reduction in risk factors. And that's certainly been the mantra of the prevention community for a long time, which I think I'm a part. I think the problem is that it does work in the people in whom it works in. But there are an awful lot of people who it doesn't. And our problem is more the people who slip through those cracks. And I think they're going to continue to do it. I don't think the world is going to adopt the DASH diet and go running out and eating it. I mean, I don't eat it, and I'm not about to. And I think I'm more prevention-oriented than, most people. So I don't think that's going to take us as far as we'd like to go, very frankly.
Yeah, I agree. Paul, a series of questions from the audience I think kind of come together. The first one, I think we know the answer, but I want to make sure you reaffirm it. Maybe talk about the variants that were adjusted for. Does the decrease in mortality with a rehab program adjust for all the other risk factors, which I think your study did, right?
The short answer is yes. It's kind of independent of all the other things that we would think would be important, that participation still associates with a lower risk.
Yeah, this other one is important. I know it pertains particularly to diabetics. Been multiple studies and meta-analyses of this. Should our patients do resistance training in addition to aerobic training? in
Yeah,
terms of-
absolutely. Thanks for that question. And I put it up on one single slide in a small way, but just to emphasize, absolutely, it's critical. It's critical for you to do as part of your workout. It's critical for your patients to do. And particularly those with diabetes, this is the metabolic kick that they need to help handle sugar and improve insulin sensitivity. At the cellular level, it actually kicks up GLUT4 transporters that actually can use sugar better. So weightlifting in modest ways. This is not pumping iron like Arnold. This is doing modest weights with moderate levels of exertion, but doing that on a regular basis, 2 or 3 times per week.
And then the final in this series, people are asking, with regards to exercise, you have a patient who's a laborer on their feet all day. Does that count as exertion? And this comes to mind because we did a study in Grenada, a large epidemiologic study, which is now going to be reported hopefully any moment now, any day now, which looked at exertion versus non-exertion and then recreational versus work-related. And there were some differences in outcome, or at least in perceived outcome. It was a cross-sectional study. But the idea that exertion that was recreational may be more healthy than exertion that is work-related. And I'm not sure, because you're asking people who are on their feet all day now to come over to the gym or do more exertion. And I'm just wondering your recommendations.
Yeah, absolutely, and we've come across that as well. The situation, so in general, obviously, it's better that you're an active person than non, so you've addressed the sedentary side of the risk factor. At the upper end of getting into appropriate intensity that may modify coronary disease, that's where we still may have some room to move on. I think that's what you're getting to, Mike, right?
Yeah.
That, so they may be active, but their heart rates may never get up above 120, for instance. So they may still benefit from that additional dose that actually can modify what's going on at the inflammatory level.
So in fact, that's a special group to pay attention to, that you don't lose them and don't forget about them. Vicky, a question from the audience. I'm a big ruminator and stressor. This is, I guess, one of our audience members. What are the resources available to me for therapy? Like, what do you do with these ruminators?
So one of the big predictors, so the reason that we look at coping styles is because coping styles are actually modifiable. So that's one of the things to look at, is to look for stress management approaches, and like I said, the cognitive behavioral approaches that focus on learning how to be aware. So it has that element of mindfulness, learning how to basically be aware of when your body is getting stressed and how to relax it, but also learning how to cognitively reframe things. So if you interpret something as the demands being more than the resources that you have, developing that ability to restructure it. And there's a lot of stress management programs that exist and a lot of mindfulness. I would look for the ones that have that combination of sort of mindfulness and relaxation, but also the cognitive restructuring, get used to changing how it is that you perceive the stressors that you have in your life.
Okay, and there's another question here. Giving the statistics in terms of motivation, what succeeds to motivate with diet and exercise? What are the real factors that are associated with, you think, with motivation?
What are the things that motivate individuals? So first of all, I think one that's very individual. It's important to find what's important to each person. What are their goals, values, wishes? I think that's the start of it. Find out what their own enablers are. And it might be to look better, feel better, lose weight, whatever those might be, but those goals need to be articulated. There's environmental things that we can fix in the system. Is it time? Is it money? Is it scheduling? Is it transportation? Sometimes those are the things, especially for women. So sometimes women need permission. I don't need to tell the women that, but your women patients sometimes do, that their health is also important, and they may not have heard that through the adventure, through the cardiac sort of realm. It may be something like daycare is the motivator, barrier, enabler that will allow that person to get through. So there's lots of things that have been well characterized in terms of behavior, and one of our UHN researchers has looked at this in extreme detail.
That's right.
Even developed a barrier scale. So important to have that conversation that follows up from go do something. Let's actually have a conversation about what's going to help you be successful there.
So Paul, you talked about moderate exertion and that was really the measure, number of hours or minutes that we participate in that. What about the weekend warriors and the hockey players that go out, intensely, maybe twice a week, 3 hours a week.
Yes.
But
So there's
do
two
they-
sides to that. So
Yeah.
so hockey players are scary because, as we know from famous Canadian New Brunswick hockey studies, that hockey can be scary, right? Lots of arrhythmia that happens in unconditioned middle-aged guys that drink too much beer before they go out on the ice. Like that's a perfect storm of bad things happening probably, right,
Yeah.
for arrhythmia. Before our guys get out to return to hockey, we want them to be in decent physical shape. So if they have an aerobic impairment to 65, at a 65% level, we want them to be reconditioned before they hit the ice. Ice is cold, you don't control exertion, your heart rates go up and down. It's fun to look at heart rate monitors. After they go chase the puck into the corner and they sit on the bench, that's when their heart rates exceed 200, right? So
Yeah.
before they don't have time to control that sort of thing. The second part of that question is it possible to get in a decent workout in a short period of time? And this interest in interval training or max rep training. And there is something to that for general population. You can do high intensity workouts for a short time and get benefit. That's probably not what you want to do with your cardiac patient though. You don't want them to be working at heart rate max, getting into ischemic or arrhythmogenic territory. So, hockey's not the first thing that we'll do with them. They might work out to it. Do the slow, steady to start with.
Got it. Mike, when we talk about the statins, and particularly when we get into ECAD, the issue of compliance, adherence, there's been a lot of emphasis on the Polypill, and I know you've thought about this a lot. Do you think that the Polypill is ready for primary prevention, and do you think it's ready for North Americans who have relatively good plans, and are we relatively more adherent? I just want you.
Yeah, I think the thing about the Polypill is it probably depends to a degree on where you are in the world. I think that in a population in North America and Canada and the United States, certainly, I think that we can be a little bit more goal-directed than that. I think that people who have very good blood pressures don't need blood pressure lowering, and I think we can pick that population out. So my enthusiasm for the Polypill is pretty limited in that setting. I think if you go to real third world settings where, in point of fact, there really isn't going to be any medical care, then you can probably make a population-based argument for using a pill that attacks more than one axis.
Right. Now, in terms of antiplatelet therapy, trials have been done, secondary prevention, charisma. And there's this feeling that in primary prevention, and now the data coming out on aspirin is looking very sort of not so definitive, right? I mean, it looks like when you weigh the risks and benefits, primary prevention aspirin probably don't really need it. It may not make that much of a difference, but yet in secondary prevention, there's a clear 25% reduction in events. So the idea is, are statins a little different? Because obviously in ECAD, we're invoking that statins are going, the hypothesis, of course, is that statins will make a difference regardless. And in fact, as you point out, which I think is very important in the ECAD trial, that is when you institute it is probably even more important.
Yeah, because I think the statins probably attack two things. One is they certainly attack the development and progression of atherosclerosis. They probably also they do stabilize plaques that people develop. I think you're going to see a big effect size with the statins. But we thought we'd see a big effect size with aspirin too. It's possible that we're wrong. It'd be important before you have the whole world on statins to, if you can study the problem, we think you can with a trial like ECAD, then I think I would go for a randomized trial and that level of evidence rather than just reasoning through it. If it weren't possible, then the discussion would change, but I think it is.
Yeah, and the primary prevention data on statins is pretty strong right now.
Yeah, I mean, it really is. The data really are there. The physiology predicts precisely what you'd expect from the epidemiology, and those two predict exactly what you'd expect from the treatment. So, I think we're on firm ground doing the statins, but I do think when you're talking about putting people on lifelong, very active drug, you really ought to, there really is a burden of proof that's necessary to do that. I was, in my enthusiasm, I would stop short of saying that you should do that without a controlled trial.
Yeah, well, we're hoping here everybody believes in the question and will participate.
Yeah, I think the question is real. I think the answer is not, is not necessarily a slam dunk.
Thank you, Vicki, Paul, and Mike, and we'll have a breakdown. Thank you.
Just a couple of instructions. Can I have the mic again? Hello. Okay, so we're going to take a break now because you haven't been fed for at least an hour. So, but we're going to make you walk out there to do that. But can we keep it to about 15 minutes, and then the next lecture will be about sleep apnea, so you could sleep afterwards. So, okay, and don't forget about your evaluation forms, and please visit our sponsors. They really get a kick out of meeting you guys out there. Thank you.